Well, good morning and welcome back to our 25th annual Research Day. Healthcare heroes. You know, we've heard those words a lot through this pandemic and for very good reason. Having a healthcare hero by your side during this pandemic has really meant the difference between life and death for tens of thousands of members of our community. And the images that often come to mind when you hear those words are physicians and nurses, respiratory therapists, environmental service team members, and frontline workers throughout our hospitals and in our outpatient centers. And you hear that again and again for good reason. You know, the incredibly talented, brave, compassionate people at work every day in our emergency rooms, our ICUs, are the best of the best. We cannot, however, forget that some healthcare heroes come in other shapes and sizes. Clinical researchers, coordinators, research nurses, investigators. They've paved the way through life-saving therapies and vaccines with their unwavering commitment, innate curiosity, clinical expertise, and they are, without question, also healthcare heroes. So today, we're fortunate to have many of those heroes walking among us. My name is Gragnolati. I have the privilege of serving as the president and CEO of Atlantic Health. I'm thrilled to see you here with us at Morristown Medical Center and virtually. I understand there's over 200 people who are connected into this. And we've got teams at Chilton and Hackettstown, Newton, Overlook, and thanks everybody for being part of this important program. You've already heard and seen this morning that research is essential to our patients' well-being and critical to the success of our organization. And Research Day is always, one of my favorites because it helps bring us together to celebrate who we are, the Atlantic Health System family, and what we do every day. And if you've heard me speak about research in the past, you've heard me say that it drives excellence. And in fact, our research program is the major reason that we have so many amazing caregivers here who choose to practice here at Atlantic Health. These scientists, physicians devote their time to research while also caring for patients in order to continually improve care. And that is, after all, why we're all here. We all know that research changes lives, provides patients and their families with more time together and hope for new therapies and cures. And in some, research empowers all of us to live healthier lives. That's really what healthcare heroes are. So today's keynote is going to be pretty special. We have 4 distinguished panelists among us, along with a moderator, somebody who is an Atlantic Health living legend, Dr. Jan Schwartzmiller, and it's just great to see you here again, Jan. But first, allow me to introduce our panelists. Dr. Avi Na. He's the clinical director of NINDS at the NIH in Bethesda. It's an organization when I was at Suburban and Hopkins that we worked a lot with. He's internationally recognized as a physician and a scientist. He serves as the advisor to the Centers for Disease Control, Food and Drug Administration, and the World Health Organization, and sits on the board of directors for the International Society of Neurovirology, having previously served as its president and recipient of its Pioneer Award for his work on neurologic infections related to HIV. So please join me in welcoming him. Dr. Zijian Chen is medical director of Mount Sinai's Union Square, where he helped launch the Center for Post-COVID Care in May of 2020. The team at the center creates personalized treatment plans for long-term COVID patients while studying their symptoms to better understand the effects of the virus and improve treatment regimes. Dr. Chen is a participating endocrinologist, internist, and primary care physician serving the New York community. He's also assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. So please welcome Dr. Chen. Dr. Rany Gandos is a clinical professor of pulmonary medicine at the NYU Grossman School of Medicine and director of both the adult cystic fibrosis and post-COVID care programs at NYU. After leading Langone's efforts to establish a long COVID clinic and patient registry, Dr. Gandos and her colleagues are now exploring the underlying mechanisms and clinical evolution behind these lingering symptoms. So please join her in welcoming her. Dr. David Sousa is the medical director of the Atlantic Post ICU Care Center and co-director of the Atlantic COVID Recovery Center. As a specialist in pulmonary critical care, Dr. Sousa helped us launch the Recovery Center in October of 2020. It was one of New Jersey's first multidisciplinary collaboratives dedicated to caring for patients with the varied and lingering symptoms of COVID. And since its launch 1 year ago, the team at the center has provided holistic post-COVID care to literally hundreds of patients across our region. So please join me in welcoming Dr. Sousa. And last but not least is our moderator for today, Dr. Jan Schwartzmiller. She retired in July after more than 30 years of caring for patients, our communities, and our team members here at Atlantic. And as our Chief Medical and Academic Officer, Dr. Jan was well known and respected for her outstanding commitment to quality, innovation, patient safety, and caring for caregivers. Her leadership of academic affairs and clinical research programs helped us create this collaborative, patient-centric culture that we enjoy and has become really the foundation for Atlantic Health's award-winning clinical excellence. So Jan, welcome back, and we look forward to the panel. Thank you.
Thank you so much, Brian, and welcome everyone this morning. It's such a, I'm going to take this off. It's such a pleasure to be back at Atlantic Health System for the 25th Annual Research Symposium. This morning, I have the privilege of joining an august group of clinicians and researchers to discuss some of the characteristics and management of long COVID. We hope to make this a discussion among the panelists, but I will start by addressing specific questions to individual panelists. Since we have a lot of ground to cover and a limited amount of time, I've asked the panelists to keep their comments as short as possible while continuing to be informative. In March of 2020, when we began to care for patients with COVID-19, we were focused on saving as many lives as possible. We did not imagine that many of the patients who had COVID-19 would continue to suffer from symptoms for a long period of time after their diagnosis. We're going to open the panel today with AHS's own Jennifer Carpentieri, who will be presenting her personal experience with COVID-19. Jennifer is a manager within AHS's Behavioral Health Department, and she is also a leader in both the development and implementation of AHS's COVID peer support groups. Jennifer, would you join us and just take some time to tell us your story?
Good morning. Thank you everyone for allowing me to be here and tell my story today. I am Jennifer Carpentieri. I am a proud member of Atlantic Health System, and as Dr. Schwartzmiller said, I am a manager within behavioral health. Prior to joining Atlantic Health, excuse me, I was the Morris County Director of Human Services and held various roles within the county for 17 years. I'm an advocate to eradicate stigma, and most recently, I have had the great honor to serve as a peer support group leader, as a COVID-19 survivor, and a long hauler. Today, I'm going to share my road and journey to recovery. On March 16th of 2020, I began to experience painful eyes, felt hot, sweaty, just very off, started to cough a little, was short of breath. That time, along with my family, and my colleagues, we all were consumed with preparing and planning for a novel virus named COVID-19 threatening to hit our area. I brushed it off as anxiety, powered through work meetings, helped my two sons with their schoolwork, and helped care for my in-laws who lived with us. We were staying vigilant, following the rules. I didn't want anybody even breathing into our home. I soon realized that whatever was going on in my lungs was much more powerful than my desire to ignore it. Then came the migraines, the GI issues, and other painful accompanying symptoms. Unfortunately, this time the Z-Paks and cough medicine didn't do the trick. I was eventually hospitalized for 6 days and relied on oxygen to help me breathe. The intensity and confluence of symptoms was unlike anything I had ever experienced. I was terrified, in a room fighting an unknown beast that was inside me, alone. My family was terrified, yet gave it their best to try not to show their growing fears. They would call, let me know what the news was saying, and one day even suggested maybe we should reserve a ventilator, just in case I needed it. Nobody was thinking clearly at that time. I vividly remember several nights where I truly believed I would not get home to my beloved family. In fact, I found myself writing farewell messages on my phone in the event I passed away. Thankfully, I was one of the lucky ones to leave the hospital. However, while I may have been home, I was far from healthy and continued to battle acute symptoms for months. Soon, the months became a year, and today, on October 6th, 2021, I'm officially a long hauler. 18 months or 569 days, to be exact. While my body continues to yearn for healing, so does my heart. Soon after my return from the hospital, my mother-in-law, who had mild dementia, was hospitalized. The next few weeks were an utter roller coaster of emotional peaks and troughs. Mom was diagnosed with COVID pneumonia and remained alone in the hospital. My husband, children, and father-in-law all had various degrees of COVID. And as the chaos coordinator that I am, I remained bedbound, trying to manage all the chaos with a cell phone and a nebulizer. After a courageous fight, Lucia Carpenteri, age 72, lost her battle with COVID on April 20th, 2020. Like so many families, we were unable to say goodbye, have a proper burial, or participate in our cultural rituals to mourn the incredible loss. For a growing number of people like myself, recovery is ongoing, painful, isolating, frustrating, and oftentimes dismissed. Recovery is not linear like other illnesses. Post-COVID recovery is filled with ups and downs. Good days followed by bad days. That's really the norm. Relapses happen without warning, some familiar symptoms, or they can be accompanied with new ones. No one knows when full recovery will happen or if full recovery will happen. And for many, damage to organs and systems are what is left for them to manage after the virus ravaged through bodies. For those of us who fell ill in early 2020, many have not returned to pre-COVID functioning, and some are still unable to return to work due to disabling symptoms. Other long haulers have lost relationships with family and friends when recovery has not aligned with others' timeline or perceived expectations that many have developed mental health issues. Being unwell for this long with more questions than answers as to why or for how long is difficult physically and emotionally. For me, excuse me, each morning I awake to the unknown. What does today present? Which body parts numb? Which one's painful? Do I need a nebulizer before I get out of my bed? The checklist is long. However, I have learned that as time goes on, acceptance becomes empowering. Acceptance does not mean that we agree or are happy with the situation. Not at all. It gives us the power to accept what's right now and focus on the things that we can control. So until such time science has more answers, we as a global community need to process the traumas we have collectively and individually experienced this past year and begin to heal mind, body, and spirit and make a path forward. As long haulers, we will need to continue to dig deep within ourselves to find that strength we perhaps didn't know was in us and find the strength to face each new day with purpose and gratitude. Find the new normal for that day. Find something to look forward to and remind ourselves better days are coming. We're all in this together and we'll emerge from the darkness more enlightened, stronger, and more grateful. My family and I will forever be grateful for our healthcare heroes. And I'm very grateful for the researchers who continue to seek answers for all of us. Thank you.
Thank you so much, Jennifer, for your willingness to tell us your story and to assist so many of our patients in their recovery. So we're going to get started with the panel discussion. And the first question I'm going to address to Dr. Sousa. And I'm going to ask you, Dr. Sousa, can you briefly define what we mean when we say that a patient has long COVID? How's it defined? What are the associated symptoms? Just to give us all a level playing field to start.
Absolutely. So there's a couple of ways we can define this. I'm going to start with the easy one. So the easy one are health problems that last 4 or more weeks after first getting infected with the coronavirus. This could be a persistence of symptoms that patients had when they were actively infected. However, what we see a lot in our center are patients who experience symptoms that are new from when they were infected. The harder definition for this is really, we're not sure, right? We don't know because we're still trying to define it, right? If you look back, Lancet had an eClinical Medicine survey that they published that described 203 symptoms that spanned 10 organ systems. The most common was fatigue, post-exertional malaise, cognitive dysfunction. At our center, our biggest need has been behavioral health, neurocog, cardiology, and pulmonology. So still evolving, still learning every day, and fortunately still getting a little bit more clarity every day.
Thank you very much, Dr. Sousa. Dr. Condos, can you discuss the frequency of this entity and if there are characteristics that might predict that somebody is going to develop long COVID during their acute course? It's interesting to me that we see this more frequently in women. Is there anything that we know that allows us to understand, enables us to understand why females seem to be affected more than men? And again, can we predict the individual who may end up with long COVID? Thank you.
Sure. First of all, I'd like to thank Jennifer for sharing her story with us. I think it's a story that we're all too familiar with, and we are struggling as a community of physicians and researchers to try to come to the answers and understanding of exactly what's causing symptoms to persist. And I also want to give a shout out to Morristown Hospital. It's the place where I first examined a patient as a medical student, and I have very fond memories of that place. So I just wanted to say that as I begin this. I think it's very difficult for us to know exactly what it is that's causing certain people to have symptoms that last a long time and others to have symptoms that tend to go away, even when we are measuring abnormalities in their lung function or in their chest radiographs. And I think that understanding what happens over time and creating registries throughout the institutions and coming together as a community to see what it is about one person that may predict that they have long COVID, and another person that has resolution of symptoms despite the fact that there's scar on their lung x-ray, I think is a very important thing. And it's these multi-center registries that are really going to be able to inform us and give us the information that we need to understand why this is more common in women. Does it have to do with autoantibodies? Is there some predisposition that's related to hormonal therapy? We're not quite sure exactly what the answer is, but I think we're beginning to collect the information that's needed in order to answer these questions.
Thank you. Does anyone want to add anything about just the definition and the incidence or frequency of long COVID before we talk a little bit about the neurologic symptoms? Okay. So Dr. Nath, as you know better than I, there are a number of neurologic symptoms, including psychiatric, that occur in patients with long COVID. I know that this is a very complicated area to discuss, but could you update us on these features and some of the research that's being conducted in this area?
Yeah, thanks for that question. Let me just start by saying that it appears to us that almost 30% of individuals who were infected with COVID at 3 months or so still complain of persistent symptoms. And if they don't get better by 3 months, chances are that those symptoms will persist for extended periods of time. Right? And the more severe the initial symptoms were, the more likely they are to have persistent symptoms. So the amount of individuals affected by long COVID in this country could run into millions of individuals. Right? So I think that is a major concern. The types of symptoms that people are experiencing are also, and everybody doesn't have exactly the same symptoms, but there's a lot of overlap between them. So you can divide them into 4 different buckets. One that complain of predominantly cognitive or psychiatric manifestations, and they often complain of brain fog. There's a second group that complains of predominantly exercise intolerance. A little bit of exercise and they can just get wiped out for the entire day. You know, one cardiologist I talked to, she said that she would just go up 1 flight of stairs and she couldn't even do telemedicine after that. She had to just lie down for the rest of the day. Then there are others who complain of autonomic symptoms. It's predominantly tachycardia. So they complain of palpitations and every time they stand up or a little bit of exertion of some sort, and they complain of tachycardia. If you really examine them, you'll find it's accompanied by some drop in blood pressure, but the hypotensive symptoms may not always be evident from the patient. And then there are pain syndromes that people complain of that overlaps with fibromyalgia, but there are also joint pains, chest pains, and the like that are also common in these patients. Then there's a last subgroup that complains of tinnitus. They complain of ringing in their ears, and they often have some decreased hearing. And these patients tend to have a lot of anxiety associated with them for whatever reason. Yeah? It goes hand in hand. So those are the really different types of manifestations that we're seeing with overlap between these manifestations.
Thank you. In some of my preparation for this panel, I learned that there is a possible relationship with myalgic encephalitis, chronic fatigue syndrome, and fibromyalgia in long haulers. And I'm hoping you can make some comment on, I know that we have a lot to learn still in this area, but in this overlap.
Yeah. So you're absolutely right. A lot of the symptoms do overlap, and we think that the pathophysiology will likely overlap as well, but they're not exactly the same. I think the symptoms here are much more severe, and sometimes there's end organ damage associated with it, so that needs to be sorted out. And there may be some differences, but yes, you're absolutely right that we've seen these kinds of symptoms with a variety of infections, and oftentimes they've been called chronic fatigue syndrome or ME/CFS.
Thank you. Dr. Condos, could you give us an update on the characteristics of long COVID and treatment modalities as it relates to the pulmonary system?
So I would say that in my post-COVID clinic, we see 3 types of post-COVID patients. Obviously, most of them are being referred because they're having some kind of pulmonary complaint. The first group is the group that had very severe COVID, where we expect that they are going to have some pulmonary limitation as a result of the severity of the initial illness, whether that's because of ARDS or whether that's because of severe pneumonia at the time of their initial presentation, or whether that's as a result of their mechanical ventilation that they may have needed at that time. It's a group of patients that we expect are going to have evidence of end organ damage by CT scan, and also we're measuring abnormalities on their pulmonary function tests as well. There's a second group of patients who may not have had a severe COVID, and yet still at the time of follow-up, they're complaining of shortness of breath, and they do have evidence on their CT scan of some perhaps fibrosis, and there may be abnormalities either in lung function due to restriction or due to obstruction, depending on what the manifestation is. And then the most frustrating group is the group that maybe had mild COVID, who has debilitating shortness of breath, and yet we are unable on testing to identify a specific reason for their persistent fatigue or shortness of breath. And that group tends to be the most, the one that we struggle with the most, because our conventional testing is not giving us an answer as to the reason for their shortness of breath. And it may be because their shortness of breath is being contributed by many other factors, including neurologic factors, autoimmune factors, and other parts of their body being affected that we're not aware of. And I think the key here is trying to keep an open mind and make sure that we're investigating these complaints as fully as we possibly can, and validating them for the patients as much as we can, as we try to move forward and understand more and more about these diseases. We have some paths forward. For example, there are studies that are being done that are directed at trying to mitigate post-COVID ARDS fibrosis. We're doing one of those studies with a drug called Bio300, where we're giving it to patients who have survived ARDS, who have evidence of end organ lung damage, and who we're trying to see if we can mitigate any long-term effects. Along those pathways, we may be able to come up with other treatments that might be beneficial for this group of patients that are complaining of shortness of breath and have evidence of abnormalities on their pulmonary function tests. But it really is a collaborative effort that needs to be between centers and amongst investigators, so that we can get a clear-cut understanding of the pathophysiology and then come up with the appropriate targets for research and for treatment.
Thank you. I just want to give the panelists a chance to weigh in on anything else related to the pulmonary issues that Dr. Condos so elegantly described. Okay, all right. So Dr. Chen, one of the striking features that Dr. Nath also referred to is the exercise intolerance, and how incredibly dramatic this can be and how affected patients are. So I'm hoping that you can talk a little bit more about your experience with this particular symptom, the characteristics of it, and the management.
Okay. Well, first, thank you, Dr. Schwarz, for having me as participate as a panelist on this research day. So our registry in the Sinai system, as well as our post-COVID clinic, has seen patients very similar to the patient demographics that is described by Dr. Condos. In regards to the patients, when we're looking at the majority of patients who had the mild cases of COVID, but now with long-term symptoms, our experience has been that perhaps less than 5% of these patients have actual new comorbid conditions that is detectable on testing. So you're talking about patients with new onset cardiac disease, atrial fibrillation, asthma, pulmonary fibrosis, or even positive pulmonary function tests. And despite these negative tests, these patients are the ones with the high self-reported symptoms are persistent in cognitive dysfunction, exercise intolerance, as well as depression and anxiety. Almost up to 40 to 50% of patients will have these symptoms on self-reporting. And to focus on the fatigue and the exercise intolerance for these patients, what we've done is we've created a program at Mount Sinai to first make sure that these patients are not suffering from anything that's physical that we can detect. The evaluation pathway includes EKG, PFTs, echocardiogram, and in some cases stress testing to ensure that the patient doesn't have anything that we can say or define as real physiologic illness or due to end organ dysfunction. And then from there, we actually engage with our rehab colleagues because much of the work that they've done pre-COVID had to do with CFS patients with chronic fatigue, and they've adapted a new program to assist these patients with these similar symptoms. The approach model what they use is called the approach model. It starts with first breath work to assist the patients in regulation of their breathing. And then as they go through this program, there is a full nutrition, psychological, psychiatric, and social work evaluation to ensure that the patient's needs in those segments are taken care of. And then after completion of the breathwork program and improvement of the breathing, as well as some fatigue, then they're referred to a physical therapist within the Sinai system or in the associated practices. And the physical therapy groups there take over and use a follow-up to the approach model, which is adapted from the Levine protocol that's used for CFS patients. And the patients working with the physical therapist, what they do is they set up goals for strength conditioning, exercise tolerance, further breath work, as well as nutritional support. And the reason for this program is that it actually begins to work for these patients. The experience that they've had working with patients in gradually improvement of fatigue and exercise tolerance has done a lot to improve the fatigue that these patients are suffering from, long COVID.
Thank you. Thank you for the description of the management of these patients. I think it's going to be necessary that this kind of information people learn throughout the United States, and certainly the Northeast had the earliest experience outside of the Northwest. So thank you, Dr. Chen. Dr. Sousa, we know that patients may develop post-intensive care syndrome after being in an ICU for an extended period of time, and we know that some patients who are in critical care for COVID will develop long COVID. How do we differentiate whether a patient has long COVID or post-ICU syndrome? Does it matter? Does it matter that we understand which it is? And does the management change at all?
Sure. That's a great question because there are a lot of parallels between the long COVID symptoms and post-ICU syndrome. For the people who are not familiar with post-ICU syndrome, it is either a worsening or a new deficit in one of the following domains. So physical function, neurologic function, or behavioral health after an ICU stay. We know that prior to COVID, up to 50% of people who have an ICU stay can have at least one PIC symptom up to 12 months out. And what's concerning is that the conditions that confer the highest risk for post-ICU syndrome are the conditions that we see in COVID. ARDS, prolonged mechanical ventilation, sepsis, and delirium are always the conditions that confer the highest risk to developing post-ICU syndrome. So from our perspective, we thought it was very important to incorporate post-ICU syndrome to our recovery center and to address this specifically. Now, in terms of differentiating, it's really difficult because as we talked about phenotypes before, in patient symptoms, they're very similar. So in the short term, our model is the same. It's systematic screening. It is getting a great history from the patients and providing them the services they need. Long term, I am interested in seeing if there is either a difference in risk or a difference in the definition, but currently the treatment is the same.
So Dr. Sousa, you'll be following this cohort to, from a research point of view to see what you can distinguish in terms of outcomes.
Yeah, that's the hope is what we're doing really now is trying to describe the population, the characteristics and phenotypes, and then obviously breaking down versus ICU versus non-ICU patients.
Okay, and I'm just curious, thank you, Dr. Sousa, and Dr. Condos and Dr. Chen, I'm just curious at your centers, which we'll talk in a little bit more depth in a few minutes, but are you observing the same things that Dr. Sousa has described at Mount Sinai and at NYU Langone?
Yes, I mean, I think that, when we first started our clinic, the plan was to follow up the survivors from the ICU. That was really what the clinic was intended to do. We didn't really imagine that patients who had COVID that wasn't severe or that patients that had COVID that were at home would have symptoms after their COVID was over. And so I think all of these clinics were initially sort of envisioned as being post-ICU care clinics, and seeing what happened to this group of COVID ARDS or COVID ICU patients and how the future was for them. It wasn't until the clinic started that, you know, patients started knocking on our doors and saying, hey, I still have symptoms. I wasn't in the ICU, or I was fine when I had my COVID, and now I can't get up the steps. So I think it really was learning on both our parts, both the patients and the physicians, in terms of what the manifestations of this disease are.
Thank you, Dr. Condos. Dr. Chen, do you want to add anything?
Yeah, I think for Mount Sinai it was slightly different. We already had an established post-ICU clinic for all three of the main hospitals within the health system. And the goal for our clinic when we started was to actually follow up the patients that we either sent home from the ER or that we saw through telemedicine who reported that they had symptoms of COVID, but we couldn't see them in the practice. At the height of the pandemic, this was about 25,000 patients that we've seen, and this was I think sometime in April. And the question for the health system was, how do we manage these patients? How do we make sure that, you know, they have some symptoms that may have been something that we could have hospitalized for, but we didn't tell them to come to the hospital because we didn't have any beds and we couldn't get them in because there were sicker patients in the hospital. And the goal of the practice was to try and encompass all of these patients and say, well, you know, we're giving you a resource to make sure that you land on your feet after your symptoms resolve. And the surprise for us was that many of the patients' symptoms never really resolved. And it was maybe weeks or months after we had seen them initially and we were still contacting the patients, and they were telling us, well, we're still sick. You told us, 2 weeks later we're supposed to be all better, but that's not the case. And that's how the practice had grown, and that's how our patient base has grown.
Well, thank you all. I think that this may bring attention to the post-ICU population and centers where they were not focusing on that, both in the COVID and the non-COVID patient population. Dr. Nath, we know that the pediatric population is becoming increasingly affected by COVID. Are we seeing kids with long COVID? Are there differences in their symptoms and their management or in their prognosis when you compare them to the adult population with long COVID?
Yeah, that's a very important aspect to discuss. Generally, the people think that children are less affected, and we've opened the schools and we send all the kids there, and now all the ICUs are full of children. So we got to look back and see what's really happening. If you look at teenagers, their incidence of neurological complications and long COVID is quite similar to that of adults. But if you go down to the lower age group, it is true that the incidence is lower in those children, but it's not insignificant. So even children less than 5 years of age after COVID will have prolonged weakness and cognitive issues that occur in these children. But you can imagine at that age, when they're just developing these kinds of symptoms, if they're persistent, that could be terrible. And I've personally done autopsies on some children. We've looked at their brains. So children get severe disease, they do die. And I think one should not minimize the types of neurological and systemic issues that occur in children. There's another syndrome that occurs in children, which is called MISC, multi-inflammatory systemic disorder. And this involves multiple organ systems. And they get inflammation not only in the brain, but other organs at the same time. And it's treatable with anti-inflammatory drugs, for example, with corticosteroids or IVIG and the like, but you have to catch them early on, and they may not get complete recovery. So, we need to recognize these syndromes early in the kids, and they need to be treated aggressively. But we shouldn't take the infection lightly when it comes to children.
I think this is so important that we emphasize this, because in the beginning, we were all relieved, right, that kids were not getting as sick as adults, and we weren't seeing the mortality. And we know that that has changed with Delta. But as we see kids with serious sequelae of COVID, I think we all need to really make sure, and I see that Walter Rose is here, so that's really
Let
great.
me just add one more thing. I think although the awareness has increased about these problems, we knew very early in the pandemic that children were being affected and children were dying. Okay, we knew very early in the pandemic that there were prolonged symptoms. I think getting the message out to people has been very hard, and that's been the biggest problem. And I wrote an editorial in March of last year describing the neurological complication in adults and kids, and that there were persistent symptoms. We anticipated that this would happen as soon as we knew there was a respiratory infection occurring of that nature. But getting it out to people has been very hard because the media and other things have really downplayed the significance of these things. And neurological complications, unfortunately, do not make the headlines. People focus on the primary organ that is involved. And every pandemic after pandemic, we have realized that the long-term consequences are primarily neurological. But that awareness comes very, very late in the thing. And that's an unfortunate aspect of the way we handle medical complications. Yeah.
I really appreciate those comments, and this is really a plea for those in the audience, both in person and virtually, to help us carry that message. And I'm sure Walter's been working on that, Dr. Rosenfeld, and will continue to be. But this is, there's a lot of tragedy associated with this in the pediatric population, in addition to the adult population. And I do think that this has been underemphasized. So really important for us to focus on. Thank you, Dr. Nath, for telling us, explaining more about this to all of us. One of the things that's striking in the New York metropolitan area, and this is partially because of the timing in which we were all affected by COVID, and partially because we have wonderful academic medical centers, is that we have 3 multi-specialty clinics that are really addressing long COVID patients. We will see, as we've watched over the last few months, what's happening in areas of the United States that had not been dramatically affected, that they will need to learn from these 3 centers and several other centers across the country that have the experience of taking care of patients with long COVID. So I'm going to be asking Dr. Sousa, Dr. Chen, and Dr. Condos to talk in a little bit more depth, and Dr. Chen already did some of this as it relates to exercise intolerance, but talk a little bit about their clinics, how they evolved, what would make a primary care physician refer to one of their clinics, what suspicion should they have for a patient having long COVID, and what the management will be, how these are structured. I think, one, it gives us a chance to learn from each other, and as you might have gathered, we have spoken before today, and begun a little bit of this conversation, but I think there's so much value. This is when I don't like that I retired. I want to get these 3 groups together. But I think there's huge value in hearing what each of these medical centers are currently doing, and value in spreading that word through research and just through support for our colleagues across the country. So I am going to start with Atlantic. We're doing this alphabetically by system. So Dr. Sousa is going to tell us the story of Atlantic and the long COVID clinic.
Sure. Thank you again. So we started back in October 2020, again, when we started seeing a lot of these persistent symptoms. And one of the important things that we knew we had to do early on was eliminate barriers to access, right? So we didn't require people to have a positive COVID test. We didn't require them to prove that they had long COVID. We really wanted to make sure there were multiple avenues into the clinic and that people were able to get in and get seen. We run it through one of our pulmonary offices, actually 2 of our pulmonary offices, but we don't function as pulmonologists in that role. We function as essentially primary care. We do systematic screening. We go through all the symptoms of long COVID and try to create a individualized treatment plan for each patient. We've been fortunate to have a pretty large collaborative to deal with COVID. Long COVID, and all of these subspecialties have agreed to see people within 10 days. We've had a coordinator that coordinates all of these appointments for patients, gets them through and navigates the system. Because, sort of like, I keep going back to post-ICU syndrome because that's my passion, but a lot of this is navigating the system, eliminating barriers, and really providing people with individualized care plans that suit their needs. To date, we've seen over 800 patients, and it's still going up. from a wide geographic area. We've seen people from New York, Connecticut, New Jersey, Pennsylvania. And if I have to think about what we learned, like acute COVID, long COVID is a heterogeneous disease. We do think, as the panel described earlier, that there are some distinct phenotypes. And that's really where our research centers around, is clinically describing who these patients are, what are the distinct phenotypes, and then trying to see if we can move on from there.
So thank you, Dr. Sousa. And for those of you who are joining us virtually, who have your hands up, who I seem to be ignoring, I'm not. But we will take questions at the end of the panel. We've left some time for that. So I'd like to move on. As I said, this is alphabetical, so we're going on to Mount Sinai. Dr. Chen already gave us some information, but I'm sure has a little bit more to elaborate on their long COVID clinic.
Yeah. So thank you again. So our long COVID clinic started in May of 2020. And as I described before, the goal was to look at the patients who were not admitted to our hospitals, but then still reporting to us symptoms of, persistent symptoms post-COVID infection. And like the Atlantic Health System program, we do have a large collaborative within the health system of specialists that we've curated over the past year to see these patients. We have urgent access. We have a coordinator that is able to facilitate access to these specialties. And when we see the patients at the primary practice, me and a group of mid-levels as well as primary care physicians, we do an intake with screening tools for each of the typical symptoms that we have for long COVID. And then beyond that, also what we do is we look for symptoms that are not the typical, because many patients, because it's such a heterogeneous disease, will come in with symptoms that day to day we've never seen before in other patients. And when those appear, we also look for other resources within the system to help assist with management of these patients' symptoms. In regards to research, we have a sponsored registry within the health system. Currently, the registry has over, I think, 1,200 patients. We at the clinic have seen over 3,000 patients already to date. And the goal of the registry is to first biobank some of the samples for the patients on a interval basis every 6 months, so that we have a repository of samples that we can use for future studies. In addition to that, there is a set of screening tools that they use also to track the patient's symptomology, as well as any new and persistent diseases and comorbid conditions that they may develop. And then on a larger scale, each of the collaborative practices within this different specialties, they have their own studies that are being run alongside with the center, and they recruit from the center. This includes the rehab division, doing the approach model and looking at patient endpoints, to doing different types of MRIs and CT scans to evaluate for cardiac and pulmonary and neurologic anomalies, and even using screening tools to look at the differences between CFS and long COVID fatigue. So a lot of work being done, and hopefully starting to get answers for what's afflicting these patients as well as how to characterize them.
Thank you, Dr. Chen. Dr. Condos, could you tell us more about the NYU Langone program?
Sure. So I'm not going to reiterate what's already been said. Our program works very similarly to the ones that were already described. From my standpoint, the focus has always been on identifying lung disease. I'm a pulmonologist and I was interested in fibrosis, and that's how the clinic actually came to be. But we do try to do a comprehensive evaluation for all these patients. And like everything, it takes a village. So there's a number of collaborators that we work with in rehab medicine, in neurology, in rheumatology, in all of the subspecialties, so that we can get access to care for these patients and try to evaluate their symptoms as fully and as best as we can. And similar to the Mount Sinai group, we do have a biorepository of specimens at various time points along the course of this disease on these patients. And for me, I think one of the things that would be nice, just because we are all getting together, and I thank the Atlantic Health System for getting us all together, is for us to think about working collaboratively. We have 200 patients, you have 500 patients, we have blood samples stored, we're all seeing similar things, but I think we need to kind of get together and kind of define what it is that we're seeing and ask questions and try to understand what the pathophysiology is. Are there autoantibodies we should be looking at? Is there some fibrotic pathway that's important and that we should be looking at? I think these are the type of questions, and having a partnership between the clinicians and the clinical scientists with the bench scientists, the translational medicine part of this is really the most important and the most valuable part, and trying to get the word out that these resources exist in the clinical realm, and what can the researchers help us, what questions can they help us answer from all of this resource that we have.
So Dr. Condos, how many patients has your program seen?
Yeah, so we've seen over 500 patients, and I'm the only provider that's currently seeing them. Until very recently, I was the only pulmonary doctor that was seeing these patients. So you can imagine that it's been a little bit busy. We have about 300 that have longitudinal blood samples that are in our registry. The rest of them are just being evaluated and referred to the various subspecialties. So again, pooling resources, getting numbers up so that we can share our information, I think is really key to answering some of these questions.
Thank you so much. And Dr. Chen, I'm just trying to show the power of numbers, the potential we have. So Dr. Chen, how many patients at Mount Sinai so far?
3,000 plus.
3,000 plus. And Dr. Sousa, Atlantic?
Little over 800.
Okay. So pooled we're over 4,000, so quite a bit over. So there's huge potential for learning from one another. Thank you all for not only taking the time to explain this, but being the people who influenced your organization to take this diagnosis so seriously and to be not only offering care, but doing the research that will help those patients with long COVID recover. When I was talking to this august group and planning this, one of the things I asked is what the primary care physician should do when they have a patient that they suspect or even might consider have long COVID. And what I was told was believe them. That was the resounding comment from the panel. I don't know whether Dr. Chen or Dr. Sousa or Dr. Condos want to add anything to that, but I just wanted to really emphasize that because I do think that just the way people who have problems post-Lyme and post a number of other illnesses, the whole chronic fatigue syndrome, how long it took us to believe that was even an entity, this is important to emphasize. So, but the clinicians who are actually taking care of these patients, any comments for the primary care physician?
Well, I would like to start because I want to echo on something that actually Dr. Nath says, which is we need to get the message out there. And the problem with this is we're still facing the acute COVID portion of the disease. And I think that the general population doesn't understand that the risk of having long-term symptoms after COVID is actually really significant. I mean, you talked about numbers just now in regards to how many patients our combined clinics have seen over the past year, which is 4,000. But I just Googled, and there's 2.5 million cases in New York State alone to date for COVID. If you're looking at a 30% rate of developing long COVID symptoms, you're talking about hundreds of thousands of patients. So the numbers we've seen in our clinics is dwarfed by the total number of possible long COVID patients that are out there in just our area. So we need to believe the patients because we need to be able to treat them. And the fact that there's going to be so many of these patients, we're going to have a lack of resources to be able to see everyone. So many of the patients will be seen by their primary care doctors, by local hospitals, and we need to, really have a good understanding and also do the work that we're doing, which is the research. But on the clinical side, we need to be able to account for everyone who's still sick.
Yeah, I so appreciate those comments. And as you can imagine, while there are all clearly pathologic reasons, physiologic reasons for behavioral and psychiatric problems associated with long COVID, there also are all the difficulties that one experiences with a chronic illness. And it's so important for people to take that seriously and make sure that that's addressed for our patients. We've all were extraordinarily relieved when the vaccine became available in December of last year, and continue to learn as we go about its benefits. But we now are facing breakthrough COVID and learning a great deal about it. But I don't understand myself, and Dr. Nath is going to help us, how breakthrough COVID will affect long COVID. And are we seeing long COVID in people who've been vaccinated and got breakthrough COVID? Is it the same entity if we are? So Dr. Nath, maybe you could please give us some insight into this.
So at the moment, we don't know a lot about breakthrough COVID. It's relatively new, but there was a paper in Lancet Infectious Disease claiming that patients have developed this so-called breakthrough COVID. If you just think about it, I mean, if you're after 2 dosages of the vaccine, if your titers are falling, that means you're no longer as protected as you were before. Then the chances of developing an infection go up. And so you have partial protection, and we know even patients with mild symptoms can develop long COVID. So it's no surprise that some of these individuals with breakthrough infections will develop long-term sequelae from the infection because the protection now is not at the level that they had before. Yet the data does suggest that they are 50% less likely to develop persistent symptoms at 12 weeks, and that the risk for hospitalization is 11 times less. Similarly, even then, all the parameters suggest that individuals who are vaccinated are still a lot better off, even if they develop a breakthrough infection.
So this is, again, information we need to get out to the public. Another reason to be vaccinated is less of a chance that you're going to get long COVID and less serious manifestations if you do. And obviously, this is very early data. But thank you, Dr. Nath. Could you make, we discussed this, but I didn't say I was going to ask it, Dr. Nath, but what we've observed in some patients who have long COVID is that they feel somewhat better when they're vaccinated. Could you talk briefly about this and how long this lasts, what efficacy there is with vaccine in relation to symptoms of long COVID?
Yeah, so you're right. So we've known that with the ME/CFS population as well, if they just get the flu vaccine or something, some of them will say that they got better for a short period of time and then they go back to where they were. In fact, the reverse is often true, is that some patients complain they get the vaccine, they get even worse in their symptoms. So I don't think that the vaccine is a cure for the long-term symptoms. I think we really need to look at the pathophysiology of this and initiate treatments that are going to alter the course of the disease.
Thank you. Thank you for those comments. I want to, if time permits, and it looks like it does, I wanted to ask Jennifer Carpentieri and David Sousa to talk a little bit about our peer support groups. But just prior to that, I want to make sure people have a chance to answer some questions, ask some questions. We have 15 minutes. Now, Stephanie Chu just sent out a mechanism for people who are not here to ask questions. I don't know whether it's going to work, but I'm going to bow to her, and if she does get questions, she can let me know. But I also will start with the audience. So is there anyone, and we'll do this for half of our remaining time, and then I'll ask Jennifer and Dr. Sousa just to talk about the peer support. So are there any questions in the audience here? Yes, Dr. Halpern. So Dr. Nath, did you hear the question?
I couldn't hear it.
Okay, so Dr. Halpern asked whether many patients are having behavioral symptoms, and they understand this to be secondary to neurologic manifestations of their illness, and he's concerned, as I'm sure others are, that they are not, and that people are becoming more worried about COVID and the long COVID manifestations because of the behavioral changes. John, is that a reasonable translation? Okay, I got it. I got it close enough.
I think Dr. Halpern is absolutely correct in saying that you have both issues here, behavioral and neurological. The patients do undergo, very difficult experience. They lose loved ones. They end up in the hospital themselves, as the patient described this morning. So it's not inconceivable that they will develop behavioral manifestations, anxiety, depression, and other things going to be part of the syndrome, and they should be treated in that way. And counseling should be provided, and if medications are necessary to treat those, it's also necessary to do so. I think he's absolutely right. Both aspects need to be looked into.
Thank you, Dr. Nath. I'm going to go to a question that was sent in or texted in. Are titers being followed with long haulers as part of the studies? If so, has a pattern been identified? I assume they're talking about antibodies. So Dr. Chen, you want to take that one?
Yeah, so during the one of the things that we do follow are titers within the registry. To be honest, it's been very variable, mostly because some of the patients with long COVID, they get the vaccine, and then what happens is their titer levels change. There are some patients who refuse to get the vaccine because they are actually monitoring their own titers along with us. And, depending on, I guess, the time of the infection and the time to, doing the test with a titer, those levels do actually wane over time. That's what we've seen. But the time to decrease is very variable, meaning the slope of the decrease, and it's really patient dependent. There really has been no kind of set pattern that we've seen with these patients.
Thank you. And Dr. Rubinson.
So there's a recent suggestion of potentially having intrapulmonary shunting similar to hepatopulmonary system. So as you guys are doing exercise testing, have you noticed if there's any shunting? Because obviously PFTs may or may not be abnormal in that population, but if they have exertional intolerance, have we gone on to bubble studies, and are you seeing any of that, or is that really more restricted to the critical care population? Thanks.
So in terms of the pulmonary patients that we're seeing, we are getting some bubble studies. We haven't found anything unusual. There's certainly a lot of interest in the microcirculation and obviously the possibility of microthromboses that we're not able to assess using our conventional PE studies on CT scans and how we can assess those. But there hasn't been anything more specific, at least in our group of patients, to support shunting within the lung itself that might explain some of the symptoms.
Thank you, Dr. Condos. Dr. Sousa, do you want to add anything?
So we also have not seen a lot on traditional bubble studies or echoes. We do have a subgroup of patients that we've been doing cardiopulmonary exercise testing on, but we haven't analyzed that data yet.
Thank you. If there's one more question before we talk about the peer support groups, but if there isn't, okay. So Jennifer, would you join us up here again? And Dr. Sousa, and as we've talked about behavioral manifestations, the need for support, neurologic problems, all the myriad of problems that our patients are seeing. So peer support's been very beneficial to these patients, and Dr. Sousa and Jennifer have been very involved in this, so I'd just like them to say a few words about it. Thank you.
Hi. So we started the peer support group in October when the program started. I run the program as not as the professional that I am, but as a peer, a long hauler myself. We found that is really beneficial because people really, there's a language that if you haven't had COVID, sitting here listening to the blood tests and some of the medical, we've become couch doctors, if you will. So there's a slight amount of that. We have not missed a week, even though I wanted to go on vacation one or two, and we still had group on vacation. We've served over 100 people so far. So some have been like me. We call ourselves the OGs of the group. We were sick in March and April, some a little bit later, but over 100 people have come in and out. Some really wanted to come in, get the answers. Why do I feel like this? Why can't I get out of bed? Why can't I'm stuttering, and this is part of what I'm working with. Why do I have brain fog? Why is this? Why is my leg numb? We don't, right? And it's not a place to get those answers, but it's frustrating, you know. So some people can tolerate talking about it and looking for coping skills, and others want the answers. So very proud and grateful to be part of the work, and we continue to get new members all the time.
Yeah, as from the ICU perspective, well, I mean, let's start non-ICU. We've been very lucky to have behavioral health support us in our post-ICU population and really provide the services needed. Patients have had tremendous benefit. We've been doing this for a while in the post-ICU population, so we've been very lucky to have an ICU team that was passionate about this. And since 2017, we were a part of the Thrive Society of Critical Care Medicine Collaborative, and we have a group that meets every month. It's facilitated by our social worker, but run by patients. We also have some ICU survivors who have taken leadership roles, and people reap tremendous amount of benefit from that team because they're able to help each other. So people get support and they give support, and we've gotten tremendous feedback from that.
We actually collaborate quite a bit with your team in the ICU. There's some overlap, and we determine which group, if not both, would benefit.
Thank you so much, both of you. So we only have a few minutes left. What I'd like to ask our panelists is, what did we forget to talk about? Is there anything that is a burning platform that we neglected to mention that you'd like to talk about for the group? There's nothing wrong with finishing early. Okay.
I just want to mention.
Yes.
I'm sorry. Well, I want to mention one
Okay.
thing is that there needs to be a focus on the support groups and the psychology and psychiatry aspect of the disease. We always see this as a physiologic manifestation of a infection, but many of the patients have very dire needs from a psychologic platform. And this is something I think the health system, my health system at least, struggles with a little bit, and I can imagine that it's happening in other health systems as well. And prior to COVID, the mention of psychiatric illness is not as prevalent in medical management as it should be. So I think it's become worse post-COVID. So it's something that we need to definitely highlight.
Thank you, Dr. Chen.
Yeah.
So
I'd like to add one thing as well, if I may, and
please.
that is, I think what I've heard, very laudatory of the efforts that you put into establishing these clinics, and this is so critical and so necessary. And it's not an easy task because these patients have multisystemic manifestations, and most often all the testing comes back negative. But these patients are suffering tremendously. It poses a challenge as to what can we do to alter the course of the illness, and besides just managing their symptoms. From what we understand so far, it appears like there is a lot of immune dysfunction that occurs in these patients. And so I'm wondering whether, while that we need to, if we need to consider doing some treatment studies at the same time while we're trying to understand this disease. So you can do a lot of pathophysiology in the context of clinical trials. So even though we may not understand all the pathophysiology really well, I think we have a lot of available drugs that can affect various arms of the immune system, and it may be worthy of considering controlled clinical trials in this patient population. You have the size and the sample size that will be necessary for these kinds of things. So I don't know what you think about it, but at least I'd like to put that on the table, if I may.
Well, Atlantic Health would be very happy to organize.
I'm in.
Okay, all right. Dr. Aburi is here, and I'm sure we will be in touch with the group so we can pursue this. This would be a great outcome of this panel discussion. Thank you. I want to thank the panelists. They've been incredibly helpful to me over the last couple of weeks as we've planned the panel. gotten to know each other a little bit and really discussed what we thought would be most worthwhile for the group today. I want to thank you all for attending. It's a pleasure to be back. Too much fun almost. I look forward to seeing all of you soon at other occasions, but most importantly, thank you to ACR for organizing this and for our panelists, Jennifer, and all of you for attending. I don't know the details on lunch, which I know probably, except for maybe Dr. Sousa, is of no importance to the rest of the panel, but somebody does who will come up and provide that information. And thanks, everyone.
Thank you.
Thank you.
Thank you.
Sure.